Yeah. So basically, we have rules in each aesthetic or facial, actually in each dental or medical treatments. Especially in dentistry, we have rules which actually figure out by Proud's theory or 3E's theory. In general, when you meet a patient for aesthetic treatment, I would like to focus on the 3E's, starting from evaluation, evaluate, and education, because education in your treatment is very important. And then estimation, which is important too, because I would like to say, when you start treatment, you have to actually get an idea about the whole estimation of your treatment, because I don't like to add something from my pocket after the treatment. So you have to evaluate, you have to estimate, you have to examine your patient first, and then do not exceed the estimation and depending on your evaluation. I don't like to increase the estimation after the treatment. I have to expect everything. I have to discuss everything. As I said last lecture, I have to write down and I have to use my verbal, because sometimes when you write down, which is actually is not understandable for your patient, to your patient. So I have to explain everything to your patient. So today, we're gonna focus on this part of the lower facial hair third, sorry, and the facial medicine and surgery, or an aesthetic facial medicine and surgery. And we're gonna discuss on non-invasive, non-surgical kind of treatment of the gummy smile. احنا بالمصطلح العلمي، المصطلح اللي هو يستعمل عادة الجامي سمايل، بس المصطلح العلمي هو gingival display or excessive gingival display, EGS. Oh, sorry, excessive gingival, EGD. It's a mistake in the slide. Basically, as a dentist or facial practitioner, to get an acceptable aesthetic smile, you have to compare 5 factors in the patient's smile. I told you guys I would like to focus on the gummy smile with botulinum toxin in this lecture, because I chose I chose a specific area in each third, because I cannot cover everything with 2 lectures. So definitely I will discuss a most important part from dental point of view. So when you got patient with the excessive gingival display or gummy smile, which is aesthetically unacceptable from your patient side, and maybe after evaluation from your side too. So the evaluation should be based on what? Should be based on dental and osseous and gingival and lips plus muscles. And here, when I say muscle, because I'm playing the game with botulinum toxin with the neuromuscular area, or neuromuscular, what they say, backyard. هذه المساحة هي جدا كبيرة بمعالجة الفيشل gummy smile. But as a dentist, you have many approaches to deal with this kind of treatment. Maybe combination of invasive and non-invasive. Maybe just non-invasive, if you are lucky. And all these scenarios depend on your evaluation. And please, when you evaluate your patient's smile, don't forget to use, remember last lecture, the dynamic and the static evaluation. I don't like to depend on the static only. You have to, to use dynamic evaluation. And I have to focus on the dynamic because I'm playing with the botulinum toxin, which is actually our aim in this lecture, how to manage the muscular hyperexcitability in perioral region. Definitely, I have to check the muscular activity, whether it's اللي حاضرين المحاضرة السابقة يتذكرون عندنا 3 categories of muscular pattern. We do have kinetic and hyperkinetic and hypertonic. As I said, hyperkinetic and kinetic, actually, most of these or most of those patterns, it's gonna get a good positive post-operative result and manageable cases. While in hypertonic, you have to consider, because at the end you have to estimate. When you evaluate and examine the case, you have to estimate, finally, maybe I will add some other kinds of material with hypertonic patient. هي لازم نضيف لها مثلا filler materials. Or we have to consider other multimodalities, adjuvant treatment in that case. So with kinetic, if you remember the classification, we got 1 or 2 wrinkles or lines, which is actually disappear when the dynamic action will disappear. While with hyperkinetic, the difference from kinetic pattern, when I ask my patient to do one movement in an area of concern, like for example, I will ask my patient to create a wrinkles between 2 glabella, at the glabellar area. So you're gonna see another wrinkles in different space, like in forehead. I'm asking to squeeze the glabellar area, but I found the glabellar plus other area, like for example, nasalis or forehead. For that, in that situation, we have hyperkinetic patient. We have to discuss that, because when you treat the glabellar, I know your patient is concerned about the glabellar, but in case of your patient not satisfied with your treatment, you have to mention that, and you have to write down that he's hyperkinetic. Maybe he's gonna ask you post-operatively about the other side. While the hypertonic is the worst scenario. So most patients, they have very deep wrinkle, and it's hard to go with this patient to other side, like hyperkinetic side, and reduce the wrinkle. But usually the wrinkling actually is manageable with different other modalities plus patulum. So the same thing you have to check with your gummy smile patient. From patient words، شو حيقول لك المريض من يجي gummy smile؟ أنت راح تشوف undesirable exposure of the gingival tissue, shortness of upper lip. Sometimes, or most of the time, those patients, they have a syndromic actually a sign and symptoms. They're gonna tell you they have like some kind of recurrent tonsillitis. They have some other types of like halitosis or some kind of gingival mouth dryness. Or all these signs, it goes with you that the patient maybe has a gummy smile. So you have to ask him about forceful excessive smiling, or you have to check this smile with hyperdynamic action or hyperkinetic action. Like ask your patient to get a social smile, a very shiny smile, plus a very excessive smile. So you have to compare between 2 different social smile and wide smiles, because at that scenario, you're gonna check the pattern of the patient's smile. So most of the patients, they complain from the photographs. They say, when ناخذ صورة احنا ما تعجبنا الصورة، الضحكة ما تعجبنا. ركزوا إنه مرات بالphotograph, most of the patients say cheese. اضحك هواية, expose your teeth. So you're gonna check the smile, because when you have to start a botulinum toxin or other kind of management for the gummy or excessive gingival display, you have to figure out which kind of smile and the reason of that smile before I start my botulinum toxin, because botulinum toxin is the end step. Maybe so I have to start other steps as a adjuvant treatment or multimodality treatment before I give my patient the botulinum toxin. For example, we do have a nice classification. I mean, there are many classifications, but I'm focusing on most 2 popular classification of gummy smile. The TJ and Miller and the Whitall's classification of excess gingival display. Some patients, they got gummy smile because as I said, there is a harmony between 5 structure, starting from teeth, gum, bone, osseous, and the lip musculature and the lip hyperexcitability or hyperactivity. I mean the muscular hyperactivity. With type A, maybe your patient has alter passive eruption of the gingival tissue. يعني من مريضك تطلع أسنانه واللثة ما تهرب apically. تبقى تصطحب السن إلى الأوكلوزال level. فهذا من النوع اللي هو احنا نسميه altered passive eruption of gingival tissue. When the gingival tissue follow the patient teeth coronally. It's supposed to be the teeth go to the occlusal plane coronally, while the gum tissue or gingival tissue goes apically, opposite to the direction of the occlusal plane. That way is actually the harmonized way of the eruption. With alternative passive, you're gonna get both of them goes coronally. So think about the gingival tissue is more coronal, so I have to manage with botulinum toxin some kind of gingival management. With B classification, bony طبعا هو A من الالتر والB من الاكسس or bony. With C, for example, gingival enlargement, and A, B, C, D. with D in deficient lip حتى تحفظوها مثلا. So B maxillary excess اللي هي most of the cases or most of severe cases when you get maxillary excess or pre-maxillary excess, which actually manageable most of the cases with botulinum plus gingivectomy and osseous surgery. So I have to start with osseous soft tissue surgery, then I will go to the botulinum toxin. Why I have to classify? Why I have to check these all these factors? Because some patients, they actually like to compare themselves with other patient, neighbors, friends, wherever, sisters. So you have to evaluate and you have to diagnose. You have to tell your patient, your sister has only, for example, gingival enlargement. And we manage her gummy smile by management of gingival tissue and the botulinum toxin. You have bony excess. I have to think about ortho, for example, or orthognathic surgery plus, but still we can manage for certain limit with botulinum toxin and gingival and osteoplasty surgery. Some patients, they have a short lip or deficient lip length, like in D. So in these cases, maybe you're gonna play a little bit with the soft tissue game, like botulinum relaxation of the upper lip and gingival depend on the place of the excess in the gingival or bony tissue, gingivoplasty or gingivectomy. And then I will show you when you to put the injection of the botulinum toxin after gingivectomy. Don't start with botulinum toxin, then you go to the gingivectomy, please. Because think usually the treatment with botulinum toxin is temporary. So you have to combine other permanent, actually, treatment of gummy smile before I start my repeated, focus on this point, my repeated botulinum toxin injection. Some patients, they have excessive lip mobility or muscular hyperactivity. Those patients are actually a golden patient for the botulinum toxins, because you're gonna play the game with hyperexcitability, which is the botulinum toxin aim to rest, to paralyze, okay? This kind of neuromuscular hyperexcitability. So that's why, first of all, I have to classify my patient and my patient gummy smile. First, when you go like عندي ضحكتي بالصورة, قول له wait, we have to check. Because you're gonna pay all these things if you are not evaluating your patient correctly. How can I check my gingival exposure or display in gummy smile patient? And then how can I classify? Definitely, I would like to check the during wide smile. I would like to check my gingival display before I start my botulinum toxins. So I have to categorize the exposure of the patient gingival area, the zenith area, for example, the keratinized area, the non-keratinized part. All these factors goes with the treatment of a gummy smile, whether it's botulinum toxin or combined with other modality with botulinum toxins. So Kokich, which is actually very famous in the gummy smiles and the smile lines and the corridors and smile curve, and if you go with the lectures for Kokich, maybe you're gonna get a lot of information about the gummy smile, especially people are dealing with gummy surgical, perio, or aesthetic, or even a conservative digital smile dentistry. So degree 1, 2 to 4 millimeter of digital display, degree 2, 4 to 8, and more than 8. So more than 8 is a questionable a little bit, but it still is treatable. And there are many lectures show the treatment with botulinum and gingivectomy for 8 milli, for example. But you're gonna discuss that with your patient about the expectation of your treatment is not like 100%. I can reduce to 2.4. I can get very nice, satisfied. I make my patient satisfied with degree 1, degree 2, but 3, 8 millimeters, when I ask the patient to get a wide, and when you instruct your patient, you have to, don't forget, you have to instruct your patient to get social smile and wide smile. So Kaukich measurement depend on the widest smile, the maximum excessive smile. So the measurement for me is important because with this measurement, I can expect, because even with botulinum toxin, I would like to keep some mild movement of my upper, for example, lip. I don't like to make my upper lip paralyzed. So definitely, I have to play another game with the gummy smile treatment or botulinum treatment of gummy smile, like for example, some kind of strip gingivectomy, gingivoplasty, or osseous surgery, and especially with degree 3. Again, when I try to figure out the reason of my patient, this excessive gingival display, I have to keep in my mind the shortness of upper lip too. So I have to measure. And you actually, most of you guys, they use this kind of vernier, or they use some kind of roller. For me, I prefer to use vernier because the caliber has a pointed end. So with pointed end, you're gonna get the exact length of the upper lip, starting from subnasally, base of the nose, to the most lower margin of the upper lip. And you can see the range in female is 21.2 millimeters, and the male 23.4 millimeters. I would like to mention here that with male, they have longer upper lip than female and more powerful muscular lip. So when you start doing botulinum toxin to the upper lip, you have to think about the hyperexcitability or the hypermobility of the maxillary lip or upper lip in male. So first of all, I have to classify, and then I have to classify the degree of the gingival display. I have to diagnose which kind of actually deformity in my patient gingival display. So all these factors are very important. Look at this picture. The difference between social smile, the difference between rest position, the difference between excessive smile, which is important because I'm playing the game to check which pattern of the hyper excitability of my patient perioral muscular structures, whether it's kinetic or hyperkinetic or hypertonic. All these factors goes with the treatment of gummy smile. I would like to mention here about the zenith gingival band, because if you play the game with gingivectomy, I mean botulinum toxin with gingivectomy, you have to respect the zenith strip. You have to know that the central and canine almost the same level with lateral incisor less than 1 meter, less than the canine and central incisor. So all these factors, plus the biotype, because I'm checking the level of my lip, of my patient lip with the gingival tissue. So gingival biotype for me, so plus, because I'm as I said, we have muscular tissue related to the upper lip, we have gingival tissue, and we have osseous and dentition. With osseous, I have to mention some golden rules how to assess if you need osseous reduction to correct the gummy smile too. If I need surgery plus the botulinum toxin. So these are 3 techniques for the assessment of the osseous level: direct and bone sounding, which is indirect, and combine CT. The question is, if my patient need both botulinum toxin treatment because of the muscular hyperactivity and gingivectomy at the same time, which one first? طبعا احنا من حددنا الايفالويشن والاكزامينيشن والاستيميشن. I have now to put my plan to treat the gingivectomy, to treat the gummy smile. And when I have to inject, because I'm focusing now on the Botox or botulinum toxins. Breger actually has a nice evaluation about the tissue rebound or tissue relapse or tissue or gingival relapse after gingivectomy. So he found in 38% after gingivectomy, most of the patients they got a stable gingival margin, no any apical or coronal migration. And in 33%, he found 1 millimeter coronal displacement and 1 to 4 apical migration, which is a good percentage. Still, we have 29% من apical migration after gingivectomy. That's why I have to wait before I start my botulinum toxin 6 weeks to 6 months, depend on the tissue rebound or tissue relapse. So please, when I combine, I have to start botulinum toxin after surgery, after my gingival surgery. all these criteria of my management, or all these factors, all these classifications, summarized by T.J. and Miller, which is very famous classification of gummy smile. And he found we have 3 major smile or design or pattern. 75 or less than 75 patient exposure with the class 1. And the class degree 2 or smile type 2 is 75 to 100% of the patient teeth exposure. You're going to see the whole tooth plus papillae. And the third classification is almost 2 or 3%. You're going to see the whole teeth structures, the gingival, attached gingiva, and maybe the mucosa or the non-keratinized mucosa, or some part of vestibular, if that is the version of the upper lip. بالمصطلحات العامة احنا نسميها هاي الثري سمايلز، مرات نسميها احنا نقول مثلا patient with Molisa smile، موليزا اللي هي ال 75 exposure of the upper maxillary teeth. Canine smiles in the middle pictures is also common, as TJ and Miller shows. The second category of the patient patterns of gummy smile. But this pattern with the canine smile, we're going to see the canine corridors or the buccal corridors very prominent. Look at the picture from the angle. You can see the black triangle at the vestibular area, plus the canine, plus the papillae of the patient. While the third one, which is rare, but still we are focusing on that part, or that of this classification, which is denture smile. With denture smile, you're going to see the whole denture is not the whole, almost most of the dentoalveolar part. So just like denture. Fortunately, it's just like 2%, but many patients treated or needed treatment of this type of smile with non-invasive. They don't like to go to the invasive side, so you're going to help them with botulinum toxin plus adjuvant and other treatment like gingivectomy or osseous resection. When you start your treatment or lip treatment or gummy smile treatment, think about the aesthetic and function and biological violation. So don't go with aesthetic only or function only, because احنا اذا ركزنا على aesthetic ونحصل flat without wrinkles, maybe مريضك ما يقدر يشرب مي with gummy smile or with management of gummy smile with botulinum toxin. So function, you have to keep in mind function plus aesthetic. The biological, I have to keep some kind of biological structure without any violation, like when you do some biological, when you do some kind of gingivectomy. So I will summarize here the invasive modality for correction of gummy smile. We are actually not focusing on these in this lecture. We're going to go to just the non-invasive. In general, when you get patient with gummy smile, you have gingivectomy management plus the patulum or without patulum. Most of the time, I like patulum if there is a degree 2 or 3. We have gingivoplasty only if your patient have gingival hyperplasia for some reason, for any kind of medications, antihypertensive, anticonvulsant. Myectomy is actually, for me, is I'm not recommending this kind, but I have to mention there's a myectomy, maybe lip stabilization technique, which is actually more actually by Dr. Khan, which is depend on the just reduction of the upper lip by cutting part of the mucosa without touching the muscular, the orbicularis oris, because when you cut the orbicularis oris, maybe you got some kind of disorientation or maybe asymmetry. Orthodontic treatment, as you know, with orthognathic surgery or combined. With non-invasive ليش راح افضل ما افضل ليش راح مريضك ممكن يفضل بدايه الباتشولم توكسينز. طبعا هو راح يكون يفكر انه هذا more conservative, no, because non-invasive, faster and safer. There is no dramatic changes. If you got something, make your patient dissatisfied, maybe you're going to wait 3 to 6 months. everything will go back. More effective sometimes, of course. Sometimes the problem is mainly to the muscular hyperactivity. So if you are working with gingiva, which is static, with teeth that are static or osseous are static, and still the hyperactivity of the patient perioral muscular structure, so you are not in correct route. You have to use a botulinum toxin plus all these. Maybe botulinum toxin will be safer and maybe faster and more conservative, and from budget point of view, maybe less expensive than other surgeries. So if the problem is with muscular part of your gummy smile, you are very easy to manage the harmony, because you're going to check your patient after 10 to 15 days. After 2 weeks, you're going to add some points. So you're going to draw, you're going to actually plan to get more symmetrical than if you cut something with surgery. Plus, it's going to help you if you have any unacceptable or your patient not satisfied with some kind of surgery. So post-operatively, you're going to manage the things with non-invasive kind of botulinum toxins. Again, as in last lecture, we have to focus on each spot, because we are dealing with the muscles. Minimally, you have to know the major muscular structure around your area of concern. Like, for example, in gummy smile, we are applying material or medication in some, actually in some part of the perioral tissue, and mainly to the muscular complex around the oral cavity. As you know, the orbicularis oris, the levator Iraqi nasalis, and then levator levi superioris, and the zygomatic major and minor, levator angularis oris. The bucconator and rizoris actually is a little bit far to the modulus part. And for the lower, maybe we discuss with the other topics. If you get patient with gummy smile, should I start botulinum toxin immediate? No, as I said, you have to classify and you have to evaluate, and then you have to decide. If I decide to do botulinum toxin for this patient, then I have to be very careful to spot or to diagnose which muscle create this unacceptable gummy smile. If you ask your patient to, if you ask your patient to show his or her teeth with excessive smile, as I said, static and dynamic smile. So I will ask for dynamic smile because I'm working with botulinum toxin, which gonna help the dynamic part of the smile. So we have a wide smile with a deep nasolabial fold. First technique. So you have to tell your patient, we have a deep nasolabial fold with your heavy or wide smile. So you have to think about the muscle or the causative muscle for that kind of smile. Then I have to reach this muscle at the special spot to relax this angular, to relax this gummy smile with a deep nasolabial fold. These 2 points goes with a point at the most labial part of the levator labii superioris alaquinesi muscle, which is responsible for the upper lip elevation with the sometime with hyperkinetic muscle. It's gonna be combined with a deep nasolabial fold. So I gonna manage both issues or aesthetic issue in that area by choosing a nasolabial, by choosing this point to relax the nasolabial and transfer the deep nasolabial fold to the flat nasolabial fold at this levator labii superioris alaquinesi muscles. As a beginner or as a actually conservative injectors, I have to choose a very small needle, like 30 to 32, which is actually great size for this type of injection because you are not deep and you are using a micro injection technique. This technique means, I mentioned that in the previous lecture, we have 2 techniques. We have micro and we have macro. With micro, I'm gonna go more superficial than macro. With micro injection, I'm gonna see a lump or white lump or like a blister of fluid, which means I am in correct plane, intradermal. And then I'm going to evaluate my patient in the next session. If there is actually insufficient relaxation, I have to go deeper with my second injection. I'm going to use macro with A, not micro with I, to reach the muscle itself. With minimum botulinum toxin or Botox dose, 2 to 3 units per point. With this port, because this port usually you have to get more dose, as we mentioned last time, 5 to 7. So both are very low volume and dose at this point. With this slide, you're going to see how to check the, the gummy smile if your patient shows a deep nasolabial too. So when you have to actually انت لازم تختار الاسئله اللي تحرك كل muscle separately sometimes. Like for example, in this muscle اللي هي levator labii superioris alaquinesi, you have to ask your patient to make smile with little bit elevation of the corner of the mouth. Heavy smile with elevation of the corner of the mouth. So at this technique, at this kind of expression or gummy smile, I have to reach this muscle. Look at the slide at the top, right top, is levator alaqui superioris nasalis muscle, which is responsible to elevate and create a deep nasolabial fold. While if I have patient with the same angular gummy smile, but with flat nasolabial fold. What should I do? Should I stay high? No, I can go more labial now. But still I am at this line of this levator labii superioris alacronese muscle. Okay? So the spot for this first one with deep fold, almost at the lateral of the ala of the nose. And you can test it with your finger when you ask your patient to make this movement, like exposing, showing his teeth forcefully. And then you're going to see the depth of the nasolabial. The second slide goes with a little bit flatter nasolabial fold. So the points goes down a little bit, but at the same line of alacronese muscles. Okay? Again, some patient with this kind of gummy smile and deep nasolabial fold, post-operatively, they got this kind of smile. راح يجي مريضك يقول لك اني كلش احس انه الزاويه قويه وبدها تصعد، هم يسموها جوكر سمايل، انه تكون الانجل كل صاعده فانت ما سيطرت على المسلز هاي. هل ممكن اعمل النقطتين سوا مع بعض؟ Of course. You can use the high level point and the lower level point to avoid this joker's smile or asymmetry or imbalance. So this one of the complication maybe commonly it will happen if you are playing or using the botulinum toxin with this alacronese. So now for alacronese we have the most upper one for the deep nasolabial fold with gummy smile, with the flat nasolabial fold with gummy smile lower bitlet, more lower than the first point. And combination, if you got patient still suffering from the severe, with each technique, whether it's high or low level, you have to use both. You have to add the missing point. Like if I gave my patient the high level point at the alacronese, maybe I will add the second one lower a little bit than the first point, or vice versa. اوكي. طبعا انتم لازم تخلون في بالكم عندنا وايد كومبليكيشن بس تتعدل. اوكي. احنا عرضنا وكتبنا واشتغلنا هوايه على الجامي سمايل. ناو راح يجيك مريضك يقول لك عندي smoking lines او يقول لك عندي wrinkles او wrinkling upper and lower. So this actually is not part of gummy smile, it's part of wrinkle and crease. Perioral, wrinkles and creases. Then again, you have to ask your patient to squeeze the upper and lower lips to check whether the crease is mostly or more prominent in the medial third or the lateral third, or both. Why I should make like that? Because I would like to check where can I put my points, to the fulcrum wrinkle side or to the lateral side, because I don't like to put too much botulinum toxin around the perioral tissue. Because you have to think, you have to keep in your mind, this area is important for drinking, sipping, for the eating, for drinking hot or cold things, for speaking too, because some letters are actually depend completely. I mean, some kind of language pronunciation depends completely on the lipsia or ellipsia. So think about that. So yeah, I prefer to focus my botulinum toxin at the site or area of concern. So first of all, if I got perioral wrinkles, I have to focus whether it's fulcrum side, medial side, or lateral to the fulcrum side, or parafulcrum area. or both could be. Definitely, both types are because of orbicularis oris. Now, we are not playing with elevators. We are playing with sphincters. So if you want to actually manage the philtrum or medial side, you have to check the philtrum lines, and you can draw with cosmetic pen the philtrum lines and cupid lines, which is V-shape between two philtrum lines. Then I have to check the dynamic result of my patient's perioral structure. Basically, I'm going to use 2 to 4 units, 2 to 4 points in the medial philtrum area. 2 on each philtrum line, or 1 on each philtrum line. Depends on how many wrinkles or the depth of the wrinkles. And some patients, they like to keep some wrinkles. Another patient, they don't like. Some patient, they got wrinkles without smoking. Other patient, they got wrinkle with smoking. Some patient, they got pattern, which is hypertonic, I mean, very deep grooves. Other patient, they don't have. They have kinetic or hyper. So with all these categories and degree of wrinklings, I have to decide to use 4 points or 2 points. But however, we are focusing on the medial philtrum area. Definitely, I'm very conservative in this area. So I have to use 1 to 2 units per side. If I use 1 point, so I will inject 1 unit per side. If I'm using units per side. With this sport, a little bit double the dose of the Botox to get the efficacy of the Botox. But sometime I'm going to use the same dose of Botox with this sport. If I'm beginner, I don't like to get a severe result, which is a severe complication, or I don't like to, dissatisfy my patient. However, very low dose, very low volume at the philtrum or median line of the upper lip wrinklings. If I'm going to use the lateral side of the upper lip wrinklings, I'm going to be save the philtrum, because my patient, when I get the same philtrum and cupid line, I don't like to play with them, because sometimes, if you go back to the previous slide, sometimes think about the flattening of the cupid line and the philtrum lines too, or cupid bows and philtrum lines, because of high dose or like double dots. For patient needs only 1 dot. So some patients, they don't like this baldness or widening of the upper lip. They like to keep the cupid actually bows, and they like to keep the philtrum lines with reduction of the wrinkles during the dynamic. So she wants, or he wants, mostly female with the dynamic, with this kind of treatment. She wants to keep the cupid bows and the philtrum lines without wrinkles. So the wrinkles means during the dynamic. But at static rest position, she want to keep down. So use 1 dot for each side, please, with 1 unit. Okay. If your patient has a wrinkling of the upper, طبعا the same thing for the lower lip. That's why المرضى اسوي وايد سلايدات، يعني الوقت تعرف، يعني احنا عندنا شويه اسئله من المحاضره السابقه، فنحاول نعطي وقت لها ان شاء الله للمحاضرتين هذه المحاضره. واذا حابين على المستقبل تابعوا، احنا راح يكون عندنا الادفانس بارت من المحاضره. فاحنا اذا نشتغل الان اللاترال ثيرد اوف ذا upper lip, because I have no cupid line bows, I have no philtrum lines, so I'm gonna get 1 to 2 points at the same level, because I'm playing with wrinkles only, without respecting the topography, like a cupid area. So goes with 2 each side or 1 each side, almost the same dose, 1 to 2. And for this sport, you have to get more, because this sport need more doses, almost double the dose, sometimes triple the dose of botulinum toxins. In general, both dissolution with 2.5 in general, according to the FDA studies. Okay, unless you are using Xeomine almost the same dose of botulinum toxin. And the good with Xeomine, as I said last lecture, you're gonna save it in the room temperature, while other Botox and Dysport at the refrigerator. Don't leave it outside. Okay. What should I do to patient with like a degree 3, like 8 millimeters? And I said, maybe you have to combine another surgeries or another modality of the treatment, like gingivoplasty, gingivectomy, or like a lip stabilization technique, only mucosa cutting without touching the muscular structure, plus botulinum. But still botulinum toxin, there are many case reports show the botulinum toxin gonna help many patients with severe gummy smile, but they use more than actually 8 points. Like this slide. They use the Alaquinase points, the high level. They use the low level Alaquinase, and they use fulcrum medial part, and they use angular part. So with these, all these points, 10 points, 8 to 10 points, to treat the severe maxillary or gingival excessive display or gummy smile, but don't exceed 20 units for all these points. And this slide shows the combination of all 4 techniques for upper lip in one patient, in degree 3 patient, according to Yule classification. And actual, according to TJ and Muller, in 3rd classification, Denture Smile. If you want, you can divide the 10 points, the dose, into 2 sessions, like 20 for the whole total dose, make it 10 for the first session and 10 to the second session at the same spot. Because with this technique, we're gonna get upon actually treatment of the denture smile according to TJ and Muller. And most of you guys with denture smile, you're gonna use this one. I'm sure that you are using this technique. But now I'm specifying the spot according to the muscles and according to the topographic structure. With the first uppermost, as I said, for Alaquinase or superioris Alaquinase, elevator Alaquinase. The one down to the first Alaquinase is the same muscles, but a little bit goes to the lower labial part of the muscles, because usually those patients, they got deep nasolabial fold too with short lip. So I have to play with the lip too plus the muscles. And fulcrum, I'm sure the fulcrum is gonna relax what? They're gonna relax medial part, because sometimes if I'm focusing with with this kind of smile, which is a denture smile, it's gonna go. If I'm not distributing the whole things, because the muscles are very hypertonic situation, I'm gonna elevate the labial or medial only. So I'm gonna go to the Joker smile. So I would like to get a symmetry, a drop of the upper lip. It's not dropping a little bit, relaxing the upper lip, and playing the situation of 2-session botulinum toxin treatment, because with that one, I can get more harmony and more symmetrical. So 8 to 10 points for degree 3 for a denture smile in TJ and Muller classification. Again, like any technique or like any botulinum toxin treatment, he got some issues. For me, all are minors, even with lid doses, with eyelid doses. Still is under control. But unfortunately, we don't have any FDA approval antidote till now. There are many studies. I would like to mention this point, guys. A lot of studies now working on the antidote or immediate antagonism to the botulinum or unwanted botulinum toxin complication. Many of these studies are not FDA approved. Like, for example, your patient, I had one case, I remember. كان الصيدلانية صار عندي اوفر دوز باللور ليب. فقالت لي انا ما اقدر اشرب مي او انشوي بالشاي. صارت. راح تقول لي شنو المانجمنت؟ راح اقول لكم بوقتها ما كنت اسوي مانجمنت، مجرد التايم فاكتور واللي هو مستحب على مرضى بعض المرضى. هي كانت يمنا بالعياده وكذا فتقبلت الموضوع، بس مو كل المرضى يتقبل. لذلك دائما ابحث على انتاجونست. ايفن ضبطت بس القطرات اللي وجدوها اللي هي كوينولين اللي موجوده بالاي ليد و that scenario completely different because you an eye lower lid, an upper lid ptosis or droopy eyelid, you are paralyzing the parasympathetic, and with that drops or eye drops, you are stimulating the sympathetic, the molar muscles. Totally different. Now I'm talking about antagonist of the neuromuscular parasympathetic area, which is paralyzed, to get rid of unwanted action of the botulinum toxin. So definitely maybe والله اذا عندنا وقت نحكيها شوي. بعض الادويه بدي تشتغل عليهم من سنه FDA. So متوقع انت ايش راح يصير عندك بالكم؟ نقول complication، نقول unwanted reaction or implications around the botulinum toxin perioral upper lip. maybe مريضك يقول لك انا ما اقدر استعمل القصبه، ما اقدر اشرب صحيح، ما اقدر انشوي. واكثرهم يضايقون ايضا من النطق، من pronunciation of some difficulty in some letters, language. However, الاesthetic complication حكينا شلون تعملوا complication جدا بسيطه. تتعامل بالدوز الثانيه. You're gonna add another dose second session, or you're gonna actually play. نحن نتعامل مع elevator وبدنا نتعامل مع depressor. So maybe you're gonna play with the muscle itself, but usually asymmetry is the most common complication. You're gonna add to the other side which is more hyperactive. بس خلوها في بالكم، لازم اقول لكم اياها. باللور ثيرد ايضا عندنا نقطه مهمه وتشوفوها انتم، هي الماريونيت لاينز والمنتولابيال لاينز، وboth are actually produced by muscular action. The angular marionette lines, for example, is usually when your patient grimacing, they got some wrinkles around the angle or droopy angle or modulus because of depressor anguli muscles, mentalis. So depressor anguli muscles actually, and sometimes part of mentalis, the lateral, goes with this marionette lines. And usually patients are not actually less, most of the patients يعني ما يتحسسون هاي المنطقة، يعني يقول لك هاي طبيعية وكذا. بعضهم no، بعضهم شو كنت يتحسس. الاولد فيميل من she got a bands or longitudinal bands or submental collection of fat, when she tried to flatten the area, she gonna notice this marionette lines. The treatment is very easy because it's triangular base of the depressor anguli muscle. Usually we have to inject 2 points at this area اللي هي كمان نشوفها بالسلايد. We are playing with what? With muscular muscles, name مالتها depressor anguli muscles. وجزء من البلاتزما، لذلك قلت لكم مريضنا من يحاول يشوف البلاتزما باند يتحسس عنده ماريونيت لاينز. ليش ده تصير؟ طبعا هي بصوره عامه احنا اكو عوامل كثيره للايجنج واحنا ناقشناها، whether it is endogenous or whether it's exogenous, whether it is environmental, whether it's genetic or combination. هذا الماريونيت لاينز actually هو combination. It depends on gravity, it depends on fat migrations او fat pad migration، ودائما تتحول خلال هالنقطه من النيزولابيال الى الماريونيت اريا الى السبمنتال اريا. So basically, botulinum toxin is going to help you to manage this cobblestones, or manage this marionette lines. But the game here is important for me to avoid what? You have to avoid the modulus of the mouth. Because if you go to the modulus level, I mean the corner of the mouth, maybe you're going to paralyze the corner of the mouth, which is important. I don't like to get droppy corner. Droppy corner is important because most of the patient, when you get to droppy corner, they're going to get what? Remember the patient with complete denture? So I'm with droppy corner, droppy modulus, they got what? Most of salivary dropping, which end up with what? With a cheilitis or candidal infection, which is actually unlikely. Basically, we are targeting the depressor anguli oris and the platysm, a little bit to the platysm band at this area. And you have to be 1 cm far from the modulus of the mouth. If you go back to the muscle action, look at the base of the muscle of the angular oris. Goes downward a little bit more than the apex of the mouth. So no need to go to the modulus set. I want to get paralysis of this muscle at the base. Most of the fiber are at the base. So why I have to go up a little bit? I have to stay at this level, at the border of the mouth, which is the safest for you and actually more functional to your patient, because we have to focus on the function and the aesthetic. And we have to stay away from biological violation. So marionette lines for me is usually with old patients, and usually female. And again, I have to stay with 2 units per point. Total, because I have 2 points, maximum 5 units per side. And for this sport, I have to double the dose. If I'm beginner, I can keep the dose just like Botox, because this sport should be higher, triple, or double the dose of the Botox, but almost the same criteria. For beginners, again, if you like to start wherever you want, like glabular, forehead, nasalis, gummy smiles, excessive display, please stay at the micro injection if you want to be in safe side. With micro injection, I can manage my patient if I'm beginner, if I'm new injector. With macro, because I'm invading the muscle part, actually, maybe it's hard a little bit to manage unless you are more professional with Botox. As I said, there is no antidotes right now. It's all antidotes need approval, FDA approval. So the FDA approval now is pending. But the good news that we are almost there to get immediate antidote, not like the droppy eyelid, as I said. Droppy eyelid, they got FDA approval for that issue. So this marionette line picture. And then again, still we have some kind of complication with marionette lines, asymmetry, most of them. Like, for example, if you are injecting one, that's why you have to use a cosmetic pen, which is very important for you to draw the lines or points to keep pure injection at the same level. Because if you go higher a little bit, for some reason, patient move or your direction is actually incorrect, you're going to go a little bit higher to the modulus or angle of the mouth. So there's asymmetry in the angular at the both side of your patient, so which is actually still under control. Okay, don't hesitate. Ask your patient, come back. That's why we have another session. And during your estimation, you have to put in your mind, there is another session, and you have to put in your mind, you have to use the botulinum toxin, which is 14 days actually reconstituted. Don't go, I don't like, many studies shows you can keep it for 6 months after reconstitution. But another ton of studies shows within 14 days is you have a maximum efficacy. If you go back, if you go more, you're gonna lose your efficacy. Okay? And then you're gonna see why my patient say she doesn't like the treatment, because your storage, your temperature of storage. Again, which kind of saline, because we got a question last time about the saline type. I would like to say a preserved saline is the best for the botulinum toxin according to the FDA. What does mean by preserved? Because we have two normal saline. Normal saline احنا ما عندنا اي اشكال بالاختيار، لازم يكون normal physiological saline 0.9 sodium chloride. Okay. Preserved saline, the product actually contains antibacterial agent and some kind of anesthetic agent, which actually make your injection less, according to the studies, and evidence shows 60% less discomfortability from the non-preserved saline. Look at خلاص اذا بتستعمل انت معها توبيك انستيزيا تخلصت من الالم. And don't mix any kind of lidocaine with botulinum toxin. Otherwise, you're going to get anaphylactic shock. According to the study, they got three cases. There are 3 case reports when the doctor makes the botulinum toxin particles with lidocaine. So be careful. Another increase in the mental or lower third area is the mentolabial, which is actually related to the mentalis muscles. I would like to say you have to be, at this point, for me, it's important. 1 to 2 points according to the cobblestone, according to the how many wrinkles, or whether hyperkinetic patient or kinetic or hypertonic, as I described before. Because sometimes patients, especially hypertonic patient, when you got patient with deep wrinkles, maybe you need to fill after the botulinum toxins. However, you have to stay in the middle. And then again, you have to check C line like in the forehead. I usually check 2 directional because sometimes at the time of your session or treatment, you will see nothing. Actually, relaxation after like 2 or 3 days, your patient send you photo and you see nothing. And then you check the patient. After 10 days, she said, still I have. But when you recheck the patient, there is no wrinkles. So when she got the wrinkles, again, like on forehead, C convergence line or line of convergence or C line. This midline lines between upper and lower, it's maybe combination between 2 directional bidirectional movement, one downward movement and the other one upward. But you have to test the movement. If I have both, so I have to tell my patient, you have 2 directional movement and you have to manage that according to which one is more further than the other. In spite of the movement, in spite of the C lines, you have to be away from the lower border and the lower lip. I'm being actually more conservative toward the lower border because I don't like to go closer to the lower lip. Because actually the flatness or baldness of the lower lip, or we can say a complete paralysis of the lower lip, which is not a good result of your treatment. Because as you remember, we have to save, we have to respect the function and aesthetic. شنو فائدة انت تتعامل مع masticatory muscles و expression muscles at the same time؟ يعني مع aesthetic ومع function. شنو الفائده اني خربت الاستاتيك والفانكشن؟ مريضك ما راح يقدر يشرب شيء يعني، فلذلك بي كونزرفاتيف استعمل مايكرو انجكشن تكنيكس اللي مور سوبرفيشال اف يو ار بيجنر. ما راح تشوف انت مشاكل عاده مثل ما اذكرها، لكن اني واجبي بالمحاضره اذكرها نعم صارت عندي. شنو فائده المحاضره اذا نحكي بس قوى عضليه؟ ما بيها فائده تكون شباب. Dose بالباتينوم toxin for the 2.4 to 8 units maximum, and this port not exceed the 10 to 20 because this port needs double or third. And the mentalis muscle is very powerful muscle. And look at the picture on the right side showing the mentalis muscle responsible for the whole scenario of the mentolabial crease. With cobblestone, almost the same. 2 points at the same level, but the things with cobblestone, I don't expect the complete clearance of the cobblestone wrinkles. كان قبل نستعمل احنا ال4 points، حقيقة كل ال4 points استعملها واشوف مريض ما مرتاح بالlower lip movement. But I decided to use 2 points, almost the same, because the muscles here almost the same, creating a mentolabial with cobblestone. But with cobblestone, the muscle more hypertonic than the mentolabial. With cobblestone, it means my patient has a gummy smile too. تقول هاي النقطة رجاء. With cobblestone, you have to think about the upper lip too, gummy smile too, because usually the muscles of the patient use the lower lip to seal, to get lips here. Because has what? Has elliptic mouth. Ellipsia has gummy smile, so try to use his muscles of the lower lip to create lipsy. So please, or oral seal. So actually أنا حاولت أركز اليوم لأن نطيت ذاك المحاضرة حسب ما عرفت أكو أسئلة، فراح نعطي وقت اليوم الأسئلة أكثر. وأنا أشكر حضوركم الحقيقة هذه المحاضرة والمحاضرة السابقة، وأنا مستعد إذا أي سؤال أقدر أجاوبه يعني ضمن يعني معلوماتي والباك جراوند. وأنا حابة يعني بالمستقبل أقدم لكم أدفانس على الفيشيال بالسي والمايوفيشيال بين والنيوروماسكولار باتشولوم توكسين مانجمنت من يصير وقت نبلغكم عن المحاضرات إن شاء الله. فشكرا للحضور، ونشكر نقابة أطباء أسنان العراق على إتاحتي هذه الفرصة.
السلام عليكم دكتور مهند.
عليكم السلام ورحمة الله وبركاته.
شلونك دكتور؟ مشتاقين.
يا أهلا ومرحبا دكتورة آلاء علي.
ايه
يا مرحبا دكتورة،
تتذكرين طبعا احنا طبعا في فرصة جدا سعيدة، لأن والله احنا دائما بذكرك ونسأل عن أخبارك. اي والله، وعاشت ايدها النقابة اللي استضافتك. وين انت هسه؟ شنو أخبارك؟
والله دكتورة أنا خلصت يعني برنامج سنة بالأكاديمية الأمريكية لزراعة الأسنان، وكملت ورجعت كملت سنة تدريبية أدفانس بروجرام بالجامعة لوما ليندا كاليفورنيا، وهسه بالتريبل اي ام اس اكاديمي للتجميل، وان شاء الله راجع خلال فتره قريبه للعراق.
الف هلا بيك والله، الف هلا. اصلا ذاك اليوم اني ودكتوره باسمه ودكتوره مها شكري بذكرك والله، ونسال عن اخبارك. حقيقه انت يعني استاذنا بهذا المجال. انا من كنت وياك اول ما بدينا بابتسامه بغداد وبعدين بمركز الحارثيه زين، ولحد الان اشتغل البوتوكس والفيلر والبي ار بي على تعليماتك والانستركشن مالتك والسيرتيفيكيت. حقيقه فد شيء يعني ان شاء الله موفق، وتستمر تنطينا هذه المحاضرات ونشوفك ان شاء الله بخير.
شكرا دكتورة. هذه المحاضره دكتوره بيزك ليتل بيت، بس انا اعرف يعني الحضور هم نيو بارتيسيبنت بهذا الفيلد. وحقيقه دا اشوف يدزوا لي مرات الصور على الماسنجر والايميل بخصوص المواضيع البيزك، فهي يعني نحتاج دائما هذه المناقشات حتى بالبيزك، يعني نخطئ مرات بالبيزك ونخطئ بالادفانس
طبعا.
اي والله دكتوره اشكرك
اكيد. يلا الف هلا بيك، وان شاء الله نلتقي بيك عن قريب ان شاء الله يا ربي. شكرا دكتور.
المرور دكتور. شكرا
جزيلا. شكرا دكتور آلاء وشكرا دكتور مهند. دكتور حاليا راح نبدا بالاسئله، لانه اكو عدد كبير يعني حتى نحاول نغطي اكبر عدد ممكن من الاسئله.
15 دقيقه للاسئله حتى تكون يعني على انت خبرتني ان تكون اسئله المحاضره السابقه ايضا مشموله بهذا.
نعم دكتور. دكتور السؤال الاول من دكتوره فاطمه الزبيدي. دكتور, if I inject Botox and the results are not accepted by patient, how to reduce the effect of Botox?
دكتوره يعني اكيد بهذه المحاضرات احنا اكدنا. شوفي دكتوره انا اقول لك شغله، بكل عمل وخاصه الاستيك ميديسن والفيشيال استيك ميديسن اللي هو الاكسبوز بارت، انا مرات من اعطي مثلا انا ما اشتغل يعني غير الفيس حكم اختصاصي وحكم شغلي ومسموح، يعني احنا لازم نعرف من حدودنا بالعمل. فحتى بالاكاديميه الامريكيه للتجميل يعني تاكد، هي صح تستقبل نيرسز وتستقبل دينتس وتستقبل دكتور وسبيشال ديفرنت سبيشال، بس كل من تقول له هذا مثل ما انت توصف الانتي بايوتيك، الدينتس ما يقدر يوصف انتي بايوتيك مثلا الجي اي تي، يوصفه علما للدنتال سورس اوف انفكشن او الفيس. وكل من يلعب بالباك يارد مالته، حديقته الخاصه، لا يطلع على الحدائق الاخرى، لان بعدين المطبات مشكله. اكو دول مترحم ترى بقوانين التجميل، قطه الصلاحيه الكل، وما خصصت فلان او فلان، بس مترحم اذا اكو خطا، لان التامين هو اعلى تامين لهذه الاعمال التجميليه اللي مال براكتس انشورنس. فسؤالك اذا صار عندي خطا، فانا fortunately ومن حسن حظنا الباتشولام توكسين هو temporary او semi permanent, is not a permanent modality of treatment. اذا انت حصله اسيمتري فالمانجمنت كلش سهل، تروحين وتشوفين الاسيمتري. هنا انا راح اشتغل بالدايناميك اكشن الحقيقيه للمريض بالاسيمتريكال والسيمتريكال بارت. ايش راح اسوي؟ راح اقول الرايت سايد مال النقطه اللي اشتغلتها هايبرتونيك والاذر سايد هايبر كاينتيك، اوكي؟ او الرايت سايد هايبر كاينتيك والليفت سايد كاينتيك. شنو قصدي؟ يعني الهايبر كاينتيك عندنا اكثر من لاين من منطقه اللي نريدها، والكاينتيك هو لاين وسيطرنا عليه بالليفت، فالرايت يحتاج فيرذر تريتمنت. ممكن اذا معالج منطقه اتعدل المنطقه الاخرى اللي حول النقطه اللي عالجتها باضافه البوتوكس، ولكن انا مسوي الباترن مالتي. اذا ترحين سبيسيفيكلي نبدي من الابر ثيرد. اكبر مشكله بالابر ثيرد هي الدروبي ايلاند، وحكيت لكم الفرق بين الميل والفيميل، وترجعين السلايدات شلون بالفيميل تخلين اصبعك على السوبرا سيلولر ريدج، بالميل اكو سوبرا سيلولر ريدج، وشلون تستعملون اذا صار عندكم دروبي ايلت تروحون على طبيب العيون يصرف الاي دروبس اللي خاصه بالمولر سيلز بالمولر ماسلز، هي سمباثيك ماسل اجونست، وتعطيك التوازن. هذا ذا كنترول. تروح على الماوث، الدروبي ماوث، اذا انت مطي الماكسيمم دوز ما راح تقدر تسوي شيء. شغله واحده تخليها في بالك، استعمل دائما، ولحد الان انا استعمل اذا منطقه حسيت فيها ما عندي ساتسفاكشن بري اور بوست المريضي طبعا بالنتيجه علي، اعمل المايكرو انجكشن تكنيك اللي هي، ودائما اكد عليها، هي احنا البيجنرز بالاكاديميه يقول لهم تستعملون المايكرو انجكشن فيرست والديسبورت سم تايم. الديسبورت اضعف من البوتوكس اذا تستعمل نفس الدوزز مال البوتوكس. اذا انت تشتغلين وتسالين سؤال حسب الاسيمتري او الديسهارموني او الانكوردينيشن موفمنت بين رايت اند ليفت سايد. فالمايكرو انجكشن من تبقين سوبرفيشال، ومن تستعملين تتاكدين من اللامبا والدام فيسيكلز، معناته انه احنا سوبرفيشال انتراديرمال. وممكن اذا اني مرتاح للانجكشن ادخل مايكرو انجكشن ديبر للمصل. هذه من العوامل اللي تساعدني. الديسبورت بالدوزز الواطئه نفس دوزز البوتوكس، احنا ما نضعفه او نعمله تريبل تايم، ممكن يعطيك اقل افيكيسي من البوتوكس باللو دوزز، وممكن اتلافى المشاكل ايضا. الشغله جدا ايضا مهمه انا اشوفها هو الدايركشن اوف ذا انجكشن اتسيلف والانجوليشن. دكتوره دائما انت حاولي بالفينجر تحسسي المنطقه، تحسسي مثلا اذا انت تشتغلين مثلا كراوس فيت او فور هيد، تحسسي المنطقه هل، لان انت اذا كراوس فيت راح تروحين على اللاترال بوردر اوف ذا اوربت وراح تشوفين المارجن هل هي وايد نورا بالفينجر، ودائما ال 1 سي ام 1 سي ام 0.5 اواي من الاوربت، والسيرنج دائما دايركشن اواي من الاوربيتال فور اكزامبل او الاورال كافيتي، والديجري تكون 30 ديجري. 30 ديجري راح تكونين بالسيف سايد اكثر. اذا تخلين صبعك جوا السرنجه راح يكون 30 ديجري، يعني من تخلين السرنجه على التشيو صبعك جوا راح تكون تمنع ان تكون انت 90 ديجري، راح تكون 30 ديجري. So all these factors actually is going to reduce. انا برايي انه الصوره ايضا مهمه، الفوتوغرافز. يعني مرات المريض يقارن نفسه بمرضى اخرين، هو ما يعرف الباترن مالتهم، ما يعرف هو هايبر او هايبر او هايبوتونيك او هايبرتونيك، ما يدري. ما يعرف انه هو الجامي سمايل مالته مثلا تتدخلين لازم جنجفكتومي او جنجيفال بلاستي، ويمكن دكتور علاء ما احسن مني بالموضوع، وتدخلين كومبينيشن، تروحين قبل تعطين باتشولام توكسين وتقولي له هاي خلص وحسن مثل هاي الاشياء لازم يعني تريبل ايز هي المهمه اللي هي ايفالويت اكزامين استيميت، وبالنتيجه المريض ترى يضوج من الاستيميشن او الاندر استيميشن، تقديرك المادي اذا كان خطا والطالبيه اكثر راح تدخلين بالمطبات. فالاستيميشن خليه عالي، او ممكن تخليه 2 ستيبس حتى المريض يقتنع انه ال1 ستيب قد تكون كافيه، لان يعني مرات تكون ال1 ستيب غير متوقعه متوقعه تحصل ساتسفاكشن للمريض، بس انت حاميه نفسك ميديكال وليجل وريتن وفيربال انه انا عندي ستيج اخرى ممكن يريدها المريض ومدفوعه لازم ندفعها. مو هي هاي الاستيميشن ترى تدخل بعمليه يعني ديساتسفاكشن للمريض ايضا. هاي الاشياء. مريض مثلا يعني يحب يكون العمل مالته، لان مرات المريض من يكون بينفول انجكشن يصير عنده حركات معينه واكسبريشن معين ياثر على شنو ياثر على شيء اسمه ديفيوجن سكيل او سبريد سكيل اوف ذا باتشنوم توكسين. حركه معينه اخ مثلا تحرك راح الباتشنوم توكسين مالتك في هذا الاكسبريشن، يفضل يكون اكسبريشن لس، بس الاكسبريشن قبل ما تعملي مانجمنت او تعملي ايفالويشن ثم اكسبريشن لس دورس انجكشن، لان هذا ممكن يعمل لك ريدايركشن او نسميه ريتروجريد سبريد، يروح الى منطقه ما نريدها احنا، ريتروجريد خلال الاكسن نيرف اكسن. انت حاولي تكون اكسبريشن لس ستيبل، وانت اذا تبدين تقللين من هالحركات ممكن تسوي له جيت ثيوري، اكو هذا الفايبريشن تخليه حتى مع المساج هذا اللي تخلوه على الظهر الصغير، خليه بجهه معينه بحيث المريض مخه كله ينشغل على النقطه دي ويبتعد عن نقطه الانجكشن. كل عوامل تساعد ان تخلصين بالاضافه الى انه ستورج مالتك لا يكون اكثر من اسبوعين حتى لا يصير الافكاسي اقل بالمره الثانيه. يعني هاي كلها التمبريتشر ستورج ايضا مهمه، الريزيرف سلاين مهم، يعني هاي العوامل اللي احنا ما بنحسها، بس هي مره مريض يجي يوجع على العلاج ومره ما يوجع، فهي كلها تعتمد على التايب اوف سلاين اتسيلف مثلا على كل. او مريض تاكدين انه ياخذ انتي بايوتيك مثلا، اذا اخذ مترونيدازول بالجلسه الثانيه لسبب ما او بالجلسه قد يكون عندك هذا دراج انتر رياكشن وذ باتش، هم نخلي باك الميديكيشن سهلي عليه.
نعم دكتور، حاليا نتوجه الى السؤال الثاني. السؤال الثاني من الدكتوره يقول به، العفو دكتور تسمعني؟
نعم واضح.
نعم دكتور، السؤال الثاني يقول به what do you think about the prognosis of Botox combined with lip repositioning flap?
I like this question. من اللي تسالني هذا الكويشن؟
اليوزر نيم، يعني ما اعرف الدكتور بس.
اوكي يعني بس تعيد السؤال بالضبط يعني حتى اشوف دقه الاجابه.
اوكي دكتور، what do you think about the prognosis of Botox combined with lip repositioning flap?
ممتاز. in degree 2 and 3 يعني عندنا من 4 إلى 8 إلى above 8 mm showing or display or gingival tissue display. According to Dr. Khan study, he prefer بالنسبة للليب repositioning شباب، احنا عندنا 3 techniques. واحدة تكون skin cutaneous، واحدة تكون mucosal، واحدة تكون mucosal مع مايكتومي مع قطع عضلي which I don't like it because أنا سويتها كم مرة والمريض ما يتعدل بعد شفته، كأنه تروح تنحرف من جلي حين ما يصير عنده adaptation، فلذلك ابتعدت عن مايكتومي حقيقة. لكن اكو سيرجري لازم تقروها اسمها السات ليب اللي هي سوري الليب ستابلايزيشن السات اس تي اي تي تكنيك تذكرتها اللي هي الليب ستابلايزيشن تكنيك، هاي احبها، هذا اسمها الجديد، هي قبل احنا نسميها من الليب لينثنينج او ليب ريدكشن او ريبوزيشن، هي هاي تستخدم احدث شيء انه يقصون فقط من الميوكوزا، طبعا من الانر سايد، نقول ميوكوزا انر سايد انر سيرفيس اوف الليب او ليبيال ستراكشر، هذه كلش رائعه. وش قد تنتظرين لازم بعد هاي العمليه؟ رجاء لا تعطون بوتوكس قبلها او تنتظروا او تعطون بوتوكس immediately، you have to wait because the study شفت فيها الدكتور كريم من السعوديه اللي هي هذه الستدي شوز انه عندنا احنا ممكن يكون عندنا ريباوند او ريلابس within 6 to 6 months، خلينا نقول 6 اسابيع شهر ونص، واي اوكي اتس فاين، لان انت بتوقع انه عندك 30% 1 to 4 الاتعس انه يصير عندك ابيكال، يعني انت ممكن تستفاد من الليب تغطي الابيكال ريلابس، راح يرجع عندك اكسبوجر، اذا عندك most of the patient with Gummy Smile, they got a prosthesis because of crown lengthening, حتى يقللون من السوفت تيشو اكسبوجر فيزيدون من طول الكراون من اوسيوس سيرجري. سو انا لازم انتظر قبل باتشيلام توكسين انا اشوف وين وصلت النهايه مالتي. القصه عندي ريلابس بس 6 اسابيع جيده مع الليب ريبوزيشنينج. for degree 2 and 3 is the best combination. Surgery and good surgery, lip repositioning plus botulinum toxin. For Tejim and Miller classification اللي هو Denture Smile, I prefer to get both. طبعا انا ما دا اقول ما نقدر نسوي عمليات اخرى بس احنا نحكي عن non invasive باعتبار محاضرتنا botulinum toxin. So that's why I يعني شرحت شويه مفصل على الجامي سمايل. الجامي سمايل هي harmony between teeth, gum, bone, lip, muscle. عنوانين السمايل مالت البيشنت يلا ابدي اختار lip positioning and botulinum toxin. lip position اكو بالسيفير دنتشر lip position reposition surgery, botulinum toxin and gingivoplasty or gingival therapy. So هذا الإجابة.
تمام دكتور. اكو سؤال اخر الدكتور يقول بي if the correct patient treatment is orthodontic surgery scientifically but the patient refused this type of a treatment, could Botox help him to reduce the severity of the case?
I just show you a slide about one case which is actually here among many case reports studies. This case basically I'm maxillofacial surgeon. When I check this case, I will say this is skeletal issue rather than dental, alveolar, or dental, or soft tissue or muscle. But if your patient for some reason يعني many patient عندهم هذا هم thalassemia. Mediterranean countries in general بيها thalassemia عالي thalassemia فهذا ممكن thalassemia ما اقدر اخذها pre-maxillary surgery or orthodontic surgery. ولا هي احسن له بتعطيك function ايضا مو بس احنا نريد function ايضا. لكن with 8 millimeters if you combine gingivectomy and some kind of botulinum toxin, I mean this case just gingivectomy and botulinum toxin with repositioning. So you're gonna solve, but still you have to get a good estimation and good patient cooperation and step by step. But the botulinum is gonna be the last session or last treatment, because with that one I'm gonna play the game. I'm gonna draw my final smile. Okay.
تمام دكتور. دكتور السؤال الآخر من دكتور ريباز يقول بي دكتور if there's any relation, is there any relation between filler or Botox with the teeth sensitivity?
With teeth?
Sensitivity.
Hypersensitivity.
نعم.
Okay, good question too. Actually, there is a report show that's why I said when you do osseous or gingival, I mean soft tissue surgery, and when you plan to do that plus botulinum toxin, wait and see 6 weeks, because apical migration 1 to 4 millimeter still expected in 39%. هذا الاكسبكتيشن راح يخليني اذا اجي اعمل باتشيلوم توكسين، فالريزن الحقيقي هو مو الباتشيلوم توكسين، الريزن الحقيقي انه انا عملت مور اكسبوجر اور ما كنت محصن من قبل المارجنز مال البون والمارجنز مال السوفت تيشو والمارجنز مال الكراون قبل ما اقرر على الباتشيلوم توكسين. لكن اذا انا حددت المارجنز مالتي ورجعت عملت ابلكيشن للاكسبوز بارت روتس اور بون ستيب، even with botulinum toxin, I can control this by relaxing more muscular activity. Then I'm going to cover the final result, but it's not a treatment, just to reduce the hypersensitivity. Yeah, it's going to reduce, but still reducing the hypersensitivity from air exposure, but not reducing the hypersensitivity from cold or icy drinks. The question is, if you are talking about the pain itself, good question too. If you go more precise, Many studies shows, and I have experience with trigeminal patient too, when you put botulinum toxin, even intraorally, I got reduce of pain. But that pain is not from hypersensitivity. Hypersensitivity can be covered by muscle relaxation, but it's not a treatment. It's just that adjuvant treatment. You have to cover the margin too, again. But for a neurologic pain, yes, it reduces a lot of pain. Okay.
تمام دكتور، حاليا اعتقد انتهت الاسئله لهذا اليوم. زملائنا الاعزاء، اذا احد عنده سؤال يقدر يكتبه الان، واذا ما بعد راح نختم. بنهايه هذه المحاضره لهذا اليوم نتقدم بالشكر الجزيل للدكتور مهند، ونتقدم بالشكر لكم زملائنا. ومثل ما في المحاضره الاولى راح يتم رفع هذه المحاضره مسجله وبشكل كامل على موقع اليوتيوب، والرابط سيتم نشره على صفحه المكتب الاعلامي لنقابه اطباء الاسنان بالعراق. بعد التطوع وبعد بعد مشكورا للدكتور مهند، قدم هذه المحاضره بشكل كامل لكون يعني تكون مرفوعه على الانترنت ليستفيد منها اي شخص، حتى اللي ما قدروا يتابعونه خلال الوقت المباشر. فشكرا جزيلا للدكتور وشكرا جزيلا لكم جميعا، وان شاء الله راح نلتقيكم في فرص علميه وفي محاضرات علميه اخرى. اتقدم لكم بالشكر الجزيل انا الدكتور عبد الله الموسوي عن التعليم الالكتروني المستمر في نقابه اطباء الاسنان بالعراق. وحاليا راح ننهي الميتنج ونتمنى لكم الموفقيه، وشكرا جزيلا للجميع. مع الف سلامه.
مع السلامه.